So you have a male patient whose background history of HCV presented following a polytrauma. Primary survey was done, and he had blood transfusion and underwent splenectomy as well. Why does the patient have bleeding tendency in that setting?
So this patient specifically has bleeding tendency because they have a past medical history of hepatitis C virus, and therefore they have a deranged liver function. They'd be unable to synthesize vitamin K and therefore factors 2, 7, 9, and 10, protein C and protein S.
Of course, that's very well done. The other thing to mention is that usually any trauma patient will be at high risk of bleeding tendency as well. And that's one of the reasons why for all trauma patients, they will be given tranexamic acid according to ATLS protocol, because they will have sort of coagulopathy due to the stress response of their body. What are the late complications of HCV?
So the late complications of hepatitis C virus would be liver cirrhosis and hepatocellular carcinoma.
And what activates the intrinsic and extrinsic pathway?
So the intrinsic pathway is due to direct vessel injury, and that releases or activates factor 12. And the extrinsic pathway is the release of tissue thromboplastin.
Okay. And how to test the intrinsic and extrinsic pathway?
So the intrinsic pathway we can measure by PT, which is activated partial thromboplastin time, and the extrinsic and common pathway is prothrombin time, PT.
Good. And what are the types of hypersensitivity reactions?
So based on which classification you choose, 4 or 5. The classification for 4 is type 1 hypersensitivity reaction, IG. That's where you get mast cells degranulation. And an example here is anaphylaxis. Type 2 is E. This is cytotoxic. This is where you have the antibody working directly against the antigen. An example could be a blood transfusion. Type 3 is E related. This is your immune complex, such as systemic lupus erythematosus. Type 4 is T cell mediated. This is delayed, so this is typically dermatitis or nickel allergy. And type 5 in some literature is reported as autoimmune, such as Graves' disease.
So I think stick to one of them. It's good that you cover both, but stick to one of them. And I think I would go with the 5 type and just stick to one of it. What's the percentage of white blood cells in a packed RBCs?
So this is less than 5 times 10 to the power of 6 cells per liter, I think.
What's the lifespan of an RBCs?
120 days.
What are the tests to do before blood transfusion?
So we do a group and save, we do a blood group, and we do a cross match.
And what is cross matching?
So cross matching is testing the donor cells specifically against the serum of the recipient, and it reduces the risk of hemolysis.
And how is it done?
It's done microscopically in a lab. So typically what happens is you'll have the donor cells and they place some droplets of blood and they look for hemolysis under a microscope.
And what are the antigens that are usually there in cross-matching?
This is antigen A and antigen B.
And what are the effects of prolonged immobility on bone?
So the effects would be reduced mineralization, so you'd get osteoporosis of bone, and then you'd also have reduced mineral density.
And why removal of an infected implant is a must if you have an ongoing infection?
So this is because a infected implant will produce a septic focus and subsequently a biofilm. It will increase virulence of bacteria and therefore will cause a fiery sepsis for the patient.
Good. What is the first test to do in infected wounds?
So I would like to do a wound swab and microbiology culture and sensitivity.
And what is PVL Staph aureus?
PVL Staph aureus stands for Panton Valentine leukocidin. It is a specific type of Staph aureus that secretes a exotoxin, which typically puts pores in the membrane of the cells that it wants to infect, and it is associated with a very virulent strain of MRSA.
Very good. It's a leukocidin, or the PVL. Very high virulence type of Staph aureus, and it can lead to, the way it does this, it creates some pores in the membranes of the infected cells, and this will cause necrosis, and it can lead to necrotic hemorrhagic pneumonia as well. All right, I tried to avoid giving feedback during the scenario. So you were timed, and I think you took about 6.5 minutes, which is great actually for the exam. I think other questions can be added. Sometimes the examiner will be jumping between different scenarios actually. For instance, they could ask you about the intrinsic and extrinsic pathway, They could ask you about hemostasis in general and how does it get activated and what's the pathway, etc. They can talk about warfarin in a scenario like this. With sensitivity reaction, they can ask you a little bit more detail about each one. And they can also talk, for example, about the renal graft failure. And then they would ask you, what is the type of this failure if it happens immediately? And then what is the type if it happens after a week, etc. Right. Okay. I think overall it's a good performance. That's really what's needed. You need to get short answers and to the point without trying to explain too much. And also you're not underdoing it. You're just giving adequate answer without overdoing it. I think overall that was good. Let me see if there was any feedback. It went very well. There isn't anything to add on this part.
The other thing of a cross match, that's difficult. Yeah.
The other thing that can be added is actually HCV, which we can do just right now.
It's a different
I know it's a different scenario, but they can ask you about it. They said recently they start to combine the scenarios or get different questions from different areas, and they can ask you about HCV as well. If you're ready for it, we can do it now. But if not,
we can give it a go.
What is HCV?
So HCV is hepatitis C virus. It's typically a RNA virus, which is single-stranded and essentially can lead to hepatocellular carcinoma as an endpoint.
So you just want to say that it's called hepatitis C virus, which is an RNA virus that affects the liver, right? So this is, I know this sounds a little bit short, but in the exam setting, you just want to be very literal and give an answer to the question that you're being asked. So I asked you, what is HCV, not what are the complications of HCV, right? So HCV is an RNA virus that affects the liver.
Yes.
The type, we said it's an RNA virus. What are the four common pathologies related to HCV?
So you've got acute hepatitis, chronic hepatitis, liver cirrhosis, and hepatocellular carcinoma.
Perfect. What's the pathophysiology of leg ulcer in this patient who was 55 female, presented with non-healing venous ulcer in the lower limb, with inguinal lymphadenopathy, and she's known to be a drug user and HCV positive.
So the pathophysiology here for the venous ulcer is that the should have potentially. Sorry, I don't know. Can we move on to the next question?
Yeah, that's fine. Going to at the end. The ulcer was swabbed and it revealed candida. What are the types of the microscopic features of candida?
So with candida, you have hyphae or pseudohyphae. There's multiple types of candida. I think there's up to 200 types. The most common one is Candida albicans, and there's other species.
The patient had inguinal lymphadenopathy. What's the structure of a lymph node?
So the structure of a lymph node would consist of a efferent and efferent vessels. There is a central focus which normally contains macrophages and other inflammatory cells that can migrate in and out of the lymph node.
What are the types of necrosis though?
So the types of necrosis would be liquidative, coagulative.
Can you give me an example for each?
So liquidative would be something. Sorry, I need to recap these.
That's absolutely fine. We're going to go through them. So HCV, you've answered it very well. It's an RNA virus, and the pathology, it goes into sequential manner: acute hepatitis, chronic hepatitis, cirrhosis, liver failure, and then hepatocellular carcinoma. The pathophysiology of ulcer, it could be multiple reasons. It could be due to a deep vein thrombosis, or the patient has increased cryoglobulinemia. All right. So I've heard that the examiners are usually not very satisfied with any answer they were given this question, which is understandable. Those are the only two reasons that I can think of in this patient to get a venous ulcer, whether they had a deep vein thrombosis and also increased cryoglobulinemia as well. The ulcer was a swab that showed candida. We have two questions here. What are the types of candida? There are multiple types, up to 200, or actually, to be exact, it's 154 species. There are 6 that are the most common: Candida albicans, tropicalis, glabarta, parapsilosis, and cruzi, and there is this one as well. To be honest, I always remember the first 3. You don't have to say the 6, but at least remember 2 or 3 of them. And the features of a candida, you need to mention the hyphae and the pseudohyphae, because this is the most characteristic feature of a candida. The patient had inguinal lymphadenopathy, the structure of a lymph node. You sort of covered it, but I think it was not. This question, it was not detailed, so you still need to find out a way to
medulla and a cortex.
Correct. So if you look at that, you have an afferent, like I said, and then efferent, and then inside you have a medulla and a cortex. So the outer layer is obviously the cortex, and the middle layer is called the paracortex, and the inner layer is called the medulla.
Yes.
And then you have a conduit, which are channels for the afferent vessels or the vessels to go through the lymph node. So the conduit, these are literally some channels for all the lymph vessels and the nodes to pass through, right? So these are considered the conduit.
Yes.
And then the efferent, and this is basically for drainage. And you need to remember just literally one thing about each layer that we mentioned. So the outer layer, which is the cortex, this contains B cells and follicles. The middle layer, which is the paracortex, this contains T cells. And the conduit, these are channels for the lymph vessels. And then the efferent, that will take away all the T and B cells, will leave via the efferent. And all this structure has to be capsulated. So this dense black thing is just the capsule around it. So if you try to break it down into these small pieces, it will be really good. The types of necrosis, there are multiple types of necrosis. You can start by, one is coagulative necrosis, and this happens usually in the lung. That is wedge shaped. Liquefactive necrosis. This is liquefied tissue. Can happen in brain infarction, an abscess, and pancreatitis as well. And you also have a gangrenous necrosis, and obviously this happens in ischemia or gangrene. Caseous necrosis, mostly in TB. Fat necrosis, this is what happens in breast after trauma. Saponification, this is what happens in acute pancreatitis. And fibrinode necrosis, this is what happens in hypertension patients, especially malignant hypertension patients. So there are multiple types, as I said. I think the most common that you should remember, coagulative liquefactive gangrenous, and also fibrinode is an important one, with fat necrosis because you've always used to it, and saponification. So this is how you should think about linking the contents of the MRCS. So polytrauma can be linked with HCV, etc. All right. Let's go to this one of those that you want to talk about today, gallbladder cancer.
It's also one that's come up recently.
Cool. So you have a patient who had open cholecystectomy, and they have developed surgical site infection, necrotizing fasciitis that was complicated by PMC. What are the risk factors of gallbladder cancer?
So the risk factors for gallbladder cancer are cholecystectomy, cholelithiasis, gallstones, chronic cholecystitis, and primary sclerosing cholangitis. Being female as well, over the age of 70, and anyone that has a gallbladder polyp.
Well done. And how does it spread, gallbladder cancer?
So it spreads via lymphatics and hematogenously. And it typically spreads to the liver, the segment of 4 and 5, porta, and to the porta hepatis.
So you're right. So it can go lymphatics and blood, and also direct spread. And given the anatomy of where the gallbladder is, it can go to the stomach, the liver, and the porta hepatis, because it's very well connected to all this area. All right. What's the pathology of gallbladder cancer?
So there's two.
Microscopic.
So there's two typical patterns. The one is infiltrative and exophytic. The exophytic looks like a cauliflower mass and grows into the lumen, whereas the infiltrative is the most common, however, carries a poorly defined thickness of the gallbladder wall.
Good. So exophytic and infiltrative, and you also have the most common carcinoma, adenocarcinoma, if we're talking about the microscopic picture. However, you can also get this adenosquamous cell carcinoma, but adenocarcinoma is going to be the most common.
Yes.
Right, we agreed before that squamous cell carcinoma usually happen in the skin and the orifices, so unlikely to happen into a secretory gland, right? So gallbladder is still secretory, so that would be more of adenocarcinoma. Breast is secretory, adenocarcinoma. The stomach is secretory, so that's adenocarcinoma, etc. Even colon is secretory, so that's adenocarcinoma as well. Yeah. Surgical site infection post-operative day 3 with yellow discharge. What do you think is going on?
So given the fact that this is yellow discharge, I'd be worried about actinomycosis, and this is because there'd be likely yellow sulfur granules present. And
what is the commonest organism causing surgical site infection?
This would be Staph aureus.
In this question, your answer was good. You will take the mark, but I would try to be, because if you think about it, when you're being asked this question in actual real life, you have a patient post-operative day 3 infection, yellow discharge. The first thing that comes to your mind is not really actinomyces.
No.
So I know the exam wants you to say that. I would be a little bit more covering the whole spectrum rather than going direct to the point. So I would say, well, this is post-operative day 3 infection. I would think first of all that this is Staph aureus or any other common organism. However, actinomycosis can be considered as well if there is sulfur granules, right? I think that would be a more reasonable answer to say. What are the organisms causing necrotizing fasciitis?
So there's three main organisms: Group A, Staphylococcus, Staph aureus, and Clostridium perfringens.
And how would you diagnose necrotizing fasciitis?
So you can diagnose it clinically. So you do full history and examination. You'd be looking for signs of sepsis such as fever, tachycardia, hypotension. Typically as well in the joints, you can notice overlying skin changes and normally crepitus as well. You can also do imaging such as a CT of the abdomen and pelvis, and you'll see intramural gas or gas present.
So it's mainly a clinical diagnosis. So lab is just to support your diagnosis. The patient will usually come septic with all the classic symptoms and toxic appearance. And the local findings, erythema, vesicles, bully, necrosis, and crepitus is very characteristic. And then the lab, you will find all the inflammatory markers are increased with deranged renal function. What's the pathophysiology of necrotizing fasciitis?
So the pathophysiology is that you get typically necrosis of the underlying soft tissues that then help form micro thrombi that can again fire off into the endothelium of distant vessels, causing widespread necrosis.
So that's right. What's the management of necrotizing fasciitis?
So management for this patient would be I'd like to manage them according to CRISP protocol. I would like to start the SITs, so I'd take a blood culture. I would like to then give them IV antibiotics according to my local trust protocol. I'd also like to inform my consultant on Gall, and it's likely, or the endpoint for this patient, it's likely that they'll need a debridement of the fasciitis of the skin, either primary or secondary stage procedure.
Very good. And who to involve in the care?
So here I'd like to involve the general surgical team, the plastic team, ITU, and the anaesthetic team, and also microbiology to ensure that antibiotics are correctly prescribed according to trust protocol.
Very good. So this patient post-operatively developed bloody diarrhea. What could be the causes for bloody diarrhea?
So the differential diagnosis for bloody diarrhea in this patient post-operatively would be C. diff, likely to the intravenous antibiotics, bowel ischemia, pseudomembranous colitis, potentially a stress ulcer, and infective hospital-acquired enteritis, gastroenteritis.
Yeah. So C. diff will be obviously the top of your list, and pseudomembranous colitis, bowel ischemia, stress ulcer, etc. But obviously, pseudomembranous colitis is the top of your list. And what's the pathogenesis of pseudomembranous colitis?
The pathogenesis of pseudomembranous colitis is when patients are on long-standing oral antibiotics that typically wipe out the normal gut flora, and therefore we get overgrowth of C. diff. C. difficile then releases a enterotoxin, which causes essentially a mucosal or mucopleural membrane of the bowel wall.
All right, very well done. And it's usually triggered by antibiotic therapy, as you said. Very good. We will go to actinomycosis because, again, that can be linked to that and be covered in it. But just as a quick feedback, so risks, you've answered it very well. Just to specify here, it can go local, lymphatic, and hematogenous, and what are the organs that it will go to. And instead of just saying local and lymphatic and hematogenous without specifying. Pathology of gallbladder, you've missed microscopic. Obviously, the examiner will not specify for you gross or microscopic, so just try to remember that yourself. Surgical site infection, I think, we'll cover this question. I would be a little bit more general here rather than going directly to actinomycosis. Staph aureus is the commonest organism. You've answered this very well. Diagnosis, be very specific that the answer to this question, the main diagnosis of necrotizing is clinical diagnosis rather than lab or radiological. So it's mainly clinical diagnosis. And it depends on the presence of crepitus in the local finding and the patient's septic and the toxemia or the toxic appearance in the septic findings. Pathophysiology, thrombosis of the blood vessels is the key. That's why you get the dark color. The management, I think this question, obviously, I'm just giving you hints here about what you're going to do. But you, to be honest, you've done it really well. You try to cover the whole spectrum in less than 40 seconds, which is our rule. So you said you're going to do CRISP protocol. You're going to do sepsis 6. You mentioned blood culture and antibiotic and the involving of microbiology and your consultant, which is really good. And then you talked about the end would be that this patient will require surgery at some point. So this is, I think, the best way to do it. Because otherwise, if you start going through CREST protocol, this patient will be very unwell, they'll be septic, they'll be confused, and they might be short of breath. They will have to do the whole A2A approach. That will take at least a minute to mention that. And then if you go through the sepsis 6 and starting antibiotic and which antibiotic you're going to give, that's another 20 seconds. And if you talk about escalation, that's another, let's say, 20 seconds. Surgical debridement, that's another 20 seconds. That's 2 minutes in total. So that's basically the whole exam gone. If you have time at the end, and that would be the advice, you can always go back to the question. Let's say you finished early, you have 1 minute at the end, you can always go back, say, well, could I please repeat the management for necrotizing fasciitis, because I think I have things to add, and they'll be very happy to accept that. And then you can start saying, well, I'll do CREST protocol, make sure this and this covered, and then you go through the whole thing again. All right. Who to involve in the GOO? You actually give a better answer here, that you're going to go get ITU, plastic surgeons, etc., a microbiologist, and basically everyone that should be involved. Bloody diarrhea, good differential, and PMC are the most common or the most relevant here. And I think you covered this well as well. So actinomycosis.
Yes.
Right. So I think it's a fairly recent scenario. It doesn't come very often, but again, people talk about it as well. So we have a male patient who was in steroids and presented with leg ulcers that produce yellowish/greenish granules. What could be the risk factors in this patient for having this presentation?
So first risk factor with the patient is on a steroid therapy, which means that they would likely to have poor wound healing, and also the patient is in a immune compromised state.
Yeah. So these are the two main risk factors. What would you do for this ulcer?
So for this ulcer, I'd like to take a wound swab, culture and sensitivity, and then await the wound swab results and contact microbiology to consider which antibiotics to put the patient on according to local trust protocol.
As soon as you incise, you get greenish pus. What's your main diagnosis?
So my main diagnosis here would be actinomycosis.
And what will you spot in this?
So typically you'll see yellow sulfur granules, which are pathognomonic.
And what type of organism is actinomycosis?
So actinomycosis is a anaerobic gram-positive filament type bacteria.
And where do actinomycosis commonly affect?
So it can typically affect the face, so cranial facial after dental surgery, but can also affect the GI tract.
So it's classically cervicofacial rather than craniofacial. So cervicofacial are the commonest areas, so you take on the cervical region in this area, but it can happen anywhere really, but the commonest is the cervicofacial area. What could happen if the mandible is affected?
So if the mandible is affected, it could result in osteomyelitis or osteonecrosis of the jaw.
What is the common source for mandible osteomyelitis?
The common sources would be after dental procedures, sepsis, and direct trauma, and also the use of bisphosphonate therapy might put the patient at risk of myelitis.
Very good. What pathogens characteristically cause actinomycosis?
I'm not too sure. Can I move on to the next question, please?
So it's basically asking for the name of the organism. Actinomycosis is obviously the disease. It's actinomyces israeli. There are multiple other types. The odontolyticus, for example, is an easy one to remember because I'm sure that the others will be difficult to remember. But this one is the one that is responsible for the cervicofacial presentation. What are the predisposing factors for actinomycosis?
So previous direct trauma to the skin, any previous facial surgery or cervical involvement that might consist of an open fracture, and I think pulmonary or lung tract.
Obviously dental surgery as well.
And dental surgery.
So I think commonly trauma and dental surgery will be probably the commonest to talk about. But it's worth knowing that we do have some commensals of actinomyces that will be found mainly in the oral cavity, alimentary tract, and the female genital system. And therefore, these are the areas that you can get actinomycosis. So for example, the oral and facial cervical region, these are dental operations. The GI tract, if you get any breakdown of the mucosal barriers because you have some commensal there, this could happen if you have any ulcer, like ulcerative colitis, diverticulitis, or you have appendicitis or anything like that. And in a female genital system, trauma could be considered, and the females are in hormone replacement therapy, pulmonary involvement as well, whether it's aspiration from aspiration pneumonia, etc. What's the characteristic course of this disease or natural history?
So actinomycosis is a very slow growing bacteria, so it has an indolent course of growth. It typically doesn't exceed its margins that it grows in. It can be associated with abdominal pain, palpable mass, typically diagnosed post-operatively, and intraoperatively you can see almost like a purse string appearance.
All right, good. And how may the diagnosis be suspected at the time of surgery?
So you would typically see yellow sulfur granules and a purse string or bag appearance. Yep. And
Yep.
based upon intraoperatively, what the only thing really that you would see.
Correct. And in terms of pre-operatively, how can you take some kind of precautions or sort of good suspicion to diagnose actinomycosis?
So if you were suspecting actinomycosis, you would do potentially a fine needle and aspiration. You should have a high index of suspicion, although there isn't any given specific test to help diagnose actinomycosis, and therefore it's predominantly a clinical diagnosis.
Very good. So I think the key to mention, like I said, to have a high index of suspicion, because we tend not to think about it, basically, because it's relatively rare. We don't really think about it, but the key point to change is to have high index of suspicion. And what is the treatment for that?
So the treatment of actinomycosis can either be surgical or non-surgical. Surgical would be normally a washout or and debridement, and non-surgical would be conservative measures with antibiotics such as penicillin.
Correct. So you're gonna give penicillin, but you can also mention for penicillin allergic patient, what will be your first line for penicillin allergic patients?
Erythromycin, clindamycin.
So clindamycin or erythromycin will be your top choices. Good. I think overall here, let me see if there was any comments. I think that was good. Again, that was okay.
So a new scenario that's come up recently as well.
Are you asking about actinomycosis if it's a new scenario?
Yeah, well, it's
I heard, yeah, that came in recently. It's only the pathogens. Just try to remember maybe two of them. Israeli odontolyticus, that would be easy to remember. Predisposing factors, I think I mentioned the two key points. You can always add more. And the way to remember this, actinomycosis or commensals in the oral cavity and alimentary tract and female genital system. And therefore, you can build your answer on that. Characteristic course, it's an indolent course. So it's a highly malignant course on the long term, but very slow. And high index of suspicion is the key to diagnose. And the treatment is mainly penicillin and surgery. Good. Let's do gastric outlet. I have a 45-year-old female patient presented with vomiting, epigastric fullness, and the lab findings are hyponatremia and pH of 7.5. What are the causes of this clinical picture?
So the clinical causes of this picture could either be benign or malignant. Benign would be pyloric stenosis secondary to a gastric ulcer, and the malignant causes would be compression from pancreatic cancer, for example.
You can get a benign or a malignant presentation. The ABG findings, can you explain them to me?
So the ABG findings show hyponatremic, hypokalemic metabolic alkalosis.
Correct. And in terms of biochemical abnormalities with gastric outlet obstructions, what are these?
You would get hypokalemia and hypochloremia and metabolic alkalosis.
Correct. So it's hypokalemic metabolic alkalosis. Right. Why bicarb is usually increased in this condition?
So the bicarbonate is increased in this condition because we want to increase excretion so it's reabsorbed by the renal tubules, and therefore the pancreatic secretion of bicarbonate is as cessation, so we don't need to secrete anymore.
That's right. The patient would have paradoxical aciduria.
So here we would have hypovolemia, which would therefore subsequently activate the renin-angiotensin-aldosterone system. And subsequently, because of that, we want to retain more chloride and water. And therefore, we get exchange of potassium and hydrogen plus ions outside of cells, so they become extracellular. And therefore, they're released more in the urine. So you have more hydrogen ions in the urine.
Perfect. Very well done. What's the management for this patient?
So here I'd like to manage the patient according to CRISP protocol. I'd want to perform a 2E examination. I'd keep the patient nil by mouth. I'd like to insert an NG tube, make sure they have IV fluids and analgesia. The NG tube can also help decompress the stomach. It's important here to note that we must give them fluids, give them normal saline, and also replace potassium. So potassium supplementation, either IV and Sandoz-K, and then I'd escalate to my consultant or registrar on call to make sure they're aware of the patient and ITU as well.
Well done. Are there any bedside tests or procedure that you can perform for this patient? You mentioned already the NG tube. Is there
Yeah.
anything else you want to do?
So here I'd like to monitor the patient's input output. So I would be wanting to put an NG tube in, and also I'd want to insert a urinary catheter. Other things that I can do, I include a baseline set of bloods, consider an ultrasound scan of the abdomen, and also perform an ABG and monitor lactate.
Perfect. And who would you involve in the care? You already mentioned your consultant. Is there anyone else that would like to involve?
So here I'd like to involve gastroenterology, the ITU registrar, and my consultant on call.
Right. Very good.
And the relatives of this patient as well.
Of course. What are the clinical picture of hyponatremia?
So the clinical picture of hyponatremia in this circumstance would be reduced GCS, delirium, and also cause seizures and fits. That's from a neurological point of view. From a respiratory point of view or cardiorespiratory, the patient might be in an arrhythmia secondary to hypokalemia.
Very good. In terms of causes of hyponatremia, what are these?
So it can be split into depletional, endocrine, and I forgot the other one. Depletional would be either renal causes or non-renal causes. The renal causes would be excess diuretic use. The non-renal causes would be GIT related, such as vomitus or diarrhea. Pseudohyponatremia would be that of multiple myeloma. Endocrine causes would consist of euvolemic, so syndrome of inappropriate ADH, and the dilutional, can be due to excess of IV fluids in TERP syndrome. It could be due to heart failure, could be due to nephrotic syndrome, and could also be due to over-administration of normal saline.
Electrolyte imbalance in gastric artery obstruction.
The electrolyte imbalance would be hypokalemia, hyponatremia, metabolic alkalosis.
It's basically the whole things that we covered, right? So it's a hypokalemic metabolic alkalosis. You can also talk about the hydrogen and potassium, etc. So the reason why I have revealed this, because I think you can make your answer better for hyponatremia causes. And
I don't know whether to split it up how you've done it, which would be either debating doing it euvolemic, hypovolemic, or hypervolemic, or split it up into dilutional, endocrine. It's really difficult to decide which one to go on because I'm not going to have time to say all of it.
I get what you mean. I think I would choose one classification and I would use it for the exam. And to be honest, not just for the exam, and real practice as well. The one that I like is depletional and dilutional, because basically with depletional, you're talking about this is hypovolemic, and dilutional, this is hypervolemic, and then euvolemic, things like SIADH, right? This is the most clinically relevant one is the dilutional, depletional, and the euvolemic, which is the SIADH. Depletional, it's easy to think about it. How do you lose fluid? By vomiting and through your kidneys, right? So renal loss, that will be whether the patient is currently in diuresis, or they are in renal failure and they have lots of diuretic phase, or after relief of a chronic obstruction and they start to give lots of diuretic phase, basically. Non-renal loss, that's through your GIT. You also lose sweat. That can happen, and very unlikely. But it's mainly the gut, so diarrhea, vomiting, fistula, things like bowel obstruction, etc. Dilutional, you have increased intake or decreased excretion or retention of water. Increased intake, such as polydipsia or psychogenic polydipsia. Reduced retention of water. Here we're talking about the kidney is not properly working, or retention of water. If you have ADH, like SIADH, or things like all the failures, right? So that would be kidney failure, cardiac failure, hepatic failure, etc., etc. All right. Endocrinological, go on.
SIADH would be euvolemic, wouldn't it, as well?
It's 100% euvolemic. It's not hypovolemic, right?
No.
Or hypervolemic. It's euvolemic. All right. That's it. So these are basically the causes. So you can literally, if you know the answer well, you can give an answer to that in 20 seconds. So say depletional, and this is due to renal or non-renal loss, and can happen in diuretic phase, for example. Dilutional, and this can happen due to water retention, such as SIADH or all the failures that include heart failure and kidney failure, nephrotic syndrome, and renal failure. And also the pseudohyponatremia and the SIADH and endocrinological causes. That will take about 20 seconds, you're done. Given that we're here already, so we can do the hyponatremia as well. You have a hyponatremic patient with sodium of 120. What is the normal level of sodium?
So the normal level of sodium is 135 to 145 millimoles per liter.
think we talked already about clinical presentation. We talked about the causes. What are the investigations you're going to offer?
So here I'd like to do some bloods. So I'd like to do a full blood count, including U's and E's, which would include EGFR, CRP, and LFTs. I'd like to use initially a serum osmolarity to determine if it was hypovolemic, hypervolemic, or euvolemic. Then I'd like to do a urine osmolarity, and then finally a urinary sodium. Other things that we can also consider would be considering other causes would be morning cortisol and thyroid function tests such as TSH, T3, and T4.
Very good. And how is ADH released and what's its function?
So ADH is released from the posterior pituitary gland in the, I think it's the paraventricle region of the posterior pituitary gland. Its cause of release would be an increase in plasma osmolarity or hypovolemia.
What's the half-life of ADH?
And the half-life is, I think, 30 minutes or less than half an hour.
It's 10 to 20 minutes though, but I think
yeah.
you're very close. What are the causes of SIADH?
So the causes of SIADH would be that from a paraneoplastic syndrome. So small cell lung cancer is typically causes SIADH, and other causes would be a malignant brain tumor.
So we talked about the classification for hyponatremia. You can do multiple classification, whether it's an acute versus chronic. What's the cutoff time for that?
So 6 months.
48 hours. So
chronic.
So acute, so it's drop of the sodium more than less than 1.3 and less than 48 hours, right? If it's more than 48 hours, this means the patient has been chronically hyponatremic. But obviously, if you just diagnose acute hyponatremia, you wouldn't wait for 48 hours and then say this is chronic. It's still acute hyponatremia, even if it's day 10, right? But if you have a patient who's been chronically hyponatremic and not very symptomatic for longer time, more than 48 hours and not particularly symptomatic, this is chronic hyponatremia. Volume status, this is the hypovolemic, hypervolemic, and euvolemic, and tonicity is the hypertonic and the isotonic, right? Management of hyponatremia.
So I would want to know, first of all, I would manage this patient according to CRISP protocol. Admit the patient to hospital. I'd want to find out the primary cause. So I'd organise some investigations such as the CT, thorax, abdomen, pelvis, and then MRI of the head if I was suspecting syndrome of inappropriate ADH. I'd also want to give a fluid infusion with different rates. So I'd give normal saline, either 0.9% or 3% on the degree of which can be quantified into mild and severe.
Yep.
Also consider doing a fluid restrictive diet if we were thinking fluid if the patient was hypervolemic.
That's right. So I think in this question, I'll give you feedback on this question, because it's very wide. You don't know what they're actually asking. You go through the basics first. You want to say, like I said, I'm going to assess the patient, take history, and examine them. And most important point in examination is to determine whether they are dehydrated or retaining fluid or basically euvolemic. This is the most difficult bit to assess during your assessment. You would like to look into the mucosal membranes, all right, to see if they're dehydrated or not, and also the skin turgor. Make sure that they are not dehydrated as well, or basically at least you get an assessment, assess for confusion, and obviously you're going to do the whole of this according to CREST protocol. And then after you do all of that, you get all the bloods. This is part of your management plan, all right? So get all the needed bloods. And then once you have established the type of hyponatremia, and I will personally follow the hypovolemic or, the status, all right? And then the tonicity as well, and the urinary sodium. And then you will reach to a final conclusion. What's the final diagnosis? And based on that, you will start managing your patient. For instance, if the patient is euvolemic hyponatremic, that's likely SIADH and can be treated by fluid restriction. And if it's something else due to the failures, the hypervolemic patients, obviously you need to address the main cause. Okay. So you need to go through the basics rather than trying to jump to a specific diagnosis and answer it. Okay, if you correct sodium rapidly.
So if you correct sodium rapidly, you can get central myelinolysis.
So it's some sort of demyelination, myelinolysis. Yeah, so you're breaking down the myelin sheath. Okay. From a previous hospital that I worked for, and it's a very, very classification. So you look at the sodium level. This is the first thing you do, and then you look at osmolality. All right, and then you will define whether it's based on the tone now, whether it's hypotonic or isotonic or hypertonic.
Yeah.
The most challenging. After
Yeah.
you get an isotonic one, you look into the volume status. And after volume status, you look at the urine sodium. Is more than 20, you're talking about SIADH. Urine sodium is in the hypervolemic patient. If it's more than 20, renal failure. Less than 20, these are the other failures like heart failure, cirrhosis, and nephrotic syndrome. For hypervolemic patient, dehydrated patient with urine sodium, high urine sodium, renal loss. Low urine sodium, this is an extra renal loss. GIT.
Yeah.
So an excellent classification, which I always used, and this is the one that I use up till now if I'm dealing with hyponatremia. All right, so let's see if there's any feedback to add here. I mean, the causes, we agreed on a classification. I think the volume one is the best one to use.
Yeah.
Investigations, I think try to the point in the investigation. I think you've mentioned lots of investigation, which is good, but I think I would go to paired osmolality and urine sodium. I'm trying to look for some causes, and that will include getting a cortisol level, your bloods, etc. But if you want to be specific here, you're talking about urine sodium and paired osmolarity and the serum sodium. Those are the key points to mention. ADH, posterior pituitary, and it's responsible for salt and water retention. Half-life is 10 to 20 minutes. The cause of SIADH, the commonest one to mention for SIADH is you're talking about trauma, especially with a skull-base fracture and some brain tumors and infection, all right? So the most common one is actually trauma. That's why if you're having to do any referral for a neurosurgeon in the country, basically, with patients, contusion or traumatic subarachnoid hemorrhage or, etc., they will always give advice as per NICE guidelines, and they will ask for a daily sodium check. All right.
Okay.
And the reason why we ask for daily sodium check, high risk SIADH. Okay. The other thing to mention, maybe lung pathology such as pneumonia and abscess and TB, etc. We talked about classification management. You said just go to the basics rather than going to a specific management, and it's myelinolysis. So you're damaging the myelin sheath. Okay. All right. I think that's perfect. We could have time to do maybe one more. Gonna do this one or continuous Whistler?
We will do the epidural if that's okay.
All right. I have a male patient who underwent lung lobectomy using thoracic epidural. Following surgery, he had hypotension, cardia, and desaturation. What are your differentials here?
So, given the patient history of hypotension and bradycardia, I would be worried about shock, distributive shock, restrictive shock secondary to hemothorax and pneumothorax, and post-operative hypovolemic shock. Another thing that I'd also be worried about is the high epidural block, which would cause either paralysis to the diaphragm or the intercostal muscles.
That's right. So lots of differentials, but epidural block will be your top differential, and also the shock as well. What are the complications of epidural anesthesia?
So the complications would be the local anesthetic being injected into the systemic circulation, so the blood vessels. So this would cause local anesthetic toxicity, so perioral numbness, metallic seizure, and tachycardia. The anesthetic also be injected into the subarachnoid space. So this can cause hypotension, bradycardia, and paralysis of the diaphragm. And then you can also have post-procedural complications such as a headache.
So, I mean, it happens due to multiple reasons, like toxicity or epidural hypotension, or the inadvertent spinal block, or the high spinal total spinal anesthesia. And I think you mentioned that in the subarachnoid space, but this one is the one that they seem to ask a little bit more about. Patient will come with hypotension, bradycardia, diaphragmatic paralysis, and the symptoms of that is dyspnea, difficult speaking, difficulty in breathing, and you need to stop the infusion, vasopressors, and reverse to Trendelenburg position to make sure that your patient is well perfused. Why does the patient have bradycardia?
So the patient has bradycardia because of the high epidural block. Subsequently, because of this, they will have the blockage of the sympathetic fibers of the thoracic region from which the cardio axillary, and because of that, they'd get unopposed blockage of vagus nerve, which is your parasympathetic system or chain.
What's your management plan in this patient, which we just mentioned about?
Yeah, so the patient is hypotensive and bradycardic. I would be worried here that this is potentially a peri-arrest. I'd manage them according to protocol, put out a peri-arrest call. I'd sit the patient upright, give them high flow oxygen via 15 litres non-rebreathable mask. I'd stop any ongoing infusions, the epidural. I would give on collaring that was responsible for the procedure and the anaesthetic team as well, and ITU. I'd consider giving them inotropic support such as epinephrine, metaraminol, and chronotropics such as atropine.
Yeah. So I think you've done it well. They're mainly looking into the initial management of this, talking about CRISP protocol and the escalation, right? Metaraminol and phenylephrine and epinephrine. It's good to mention, but not necessary, to be honest. That will be up to RTU to decide. Okay. Factors affecting epidural efficiency.
So the patient factors would be age and weight, and the procedural factors would be the posture of the patient, the volume of the drug, the type of medication, and the dose of the drug injected, and also the efficacy of metabolism.
Why do you think epidural is sometimes preferred?
So an epidural is sometimes referred and most commonly used now in the UK for its enhanced recovery pathway. It helps with patient mortality and morbidity as they're able to mobilize quickly and reduce level of DVT. They also have very good outcomes and can also be used to anesthetic and analgesia as well.
And how will you test the level of block?
So we can test the level of block using cold ice packs or ethanol chloride spray.
And how do you use temperature sensation rather than pinprick sensation?
So temperature sensation is used over pinprick because pinprick can increase the risk of infection. It can cause pain and it can cause bleeding.
Very good. How do you differentiate by high epidural block from block?
So a high epidural block will cause bradycardia. Patients will typically be well perfused distally and have warm and pink peripheries, whereas in hypovolemic shock, they'll be tachycardic due to the increase in systemic vascular resistance, and they'll also be cold and clammy.
Yeah. Okay. Overall, good performance in this one as well. There's nothing really to add. I think you covered the main points. And okay, that will be probably it. The rest we can eventually defer to
Yes.
the next time.
Thank you.
Stop recording there.